You're good? Okay. Okay, great. If anything comes up that doesn't make sense in your UWorld or whatever, let me know. I'll be happy to review it again with you. In the meantime, I redid the slides for Hemonc, and I separated it. So we're just going to do all of hematology, all red blood cell stuff, platelet stuff today. And then we're going to do all of the oncology stuff when we meet on Wednesday. So that'll be all of the lymphomas, leukemias, myelomas, all that fun stuff we're going to tackle on Wednesday. Today, we're just talking about anemias, platelet problems, hemophilias, and things like that. Okay. The PDF has been updated. If you check that spreadsheet thing that I sent you early on, it has been updated reflecting the change. Okay. Okay, great. So what are we talking about today? We're talking really about three things. My idea with redoing these slides is to make it as not painful as possible, right? Normally hematology is pretty painful. Let's be honest. It's like they all kind of sound similar, and the names are very strange, and they don't really connect with what you're seeing in the patient. And so we're going to take it at a very not painful way. We're going to talk about three things. We're going to talk about anemias. We're going to talk about platelets and coagulation. We have two different pathways there. And we're going to talk about hypercoagulability. What happens when a patient starts clotting like crazy? Why does it happen, and what do we do? So let's get right into it. When we first start off by talking with anemia, any condition where you lack enough red blood cells to carry oxygen to your body is an anemia. Okay, you can have problems with one of the components of the red blood cell. You can have a drop in the overall number of red blood cells. You can have a destruction of your red blood cells, which would kind of fall into that second category. There's a number of different ways to get anemias, and so in order to kind of drill down and categorize these different ways, what we do is we look at the size of the red blood cell. We say macrocytic, normocytic, and macrocytic, okay? And so that's going to refer to the actual size. The MCV is the actual size of the red blood cell. That's what that's referring to. When you see microcytic MCV less than 80, that means it's a smaller red blood cell. Normocytic is anywhere from 80 to 100. This is a regular sized red blood cell, but you're still anemic. Why is that? And then macrocytic means we have a large, big balloon red blood cell. And so there's not too many things that cause that. And so that's going to really make it easy for us to figure out what's going on. Okay. Great. So just kind of zooming in up close to a red blood cell to get our basic terminology. All of the components of the red blood cell are all of the places something can go wrong and give us an anemia. So we're going to start on the outside of the red blood cell with the membrane. The membrane is built up of a regular phospholipid membrane. As you can see here, we have the two phospholipids on either side sort of opposing one another. It's going to prevent any electrolytes from moving out of the cell, anything from moving into the cell. It's a nice barrier. In that barrier, we have a skeleton, which gives our red blood cell its flexibility, and it gives the red blood cell its strength. And so when you think about the normal shape of a red blood cell, a lot of times it's described kind of like an inner tube, like when you go tubing, down the river, you can kind of go onto an inner tube. And so the fact that the red blood cell has this sort of shape is because of these cytoskeleton proteins that are there. Okay, and so you can see spectrin and anchorin. If we look on our image here, we can see that spectrins are these sort of longitudinal pieces of the cytoskeleton that will run parallel with the membrane, and anchorin is going to anchor the cytoskeleton to the membrane itself. And so you need all of these proteins in order to have a nice flexible red blood cell membrane. Red blood cells, they're moving at a high speed, a high velocity through our arteries, through the arterioles, down to the capillaries. As they're moving through that high velocity, they're going to reach points where, say, you're moving along this artery, and then that artery branches into two. And if you're moving at a very fast speed and then you're hitting a branch point, there's a chance that you can break open. However, because of these proteins, our red blood cells don't just break open whenever they hit one of these forks in the road. They just sort of flex and then continue on their merry way. They're not going to break open just because they are meeting points, in the road where there's some sort of bifurcation. And that's because of this cytoskeleton. Spectrin and anchorin, very important, and that's somewhere where we can have a deficiency, something can go wrong, giving us an anemia. Next are our enzymes. Enzymes are very important to red blood cells. The reason is because red blood cells do not have a nucleus and they do not have mitochondria. Okay? So in terms of generating energy, if you don't have mitochondria, what can't you do? You can't do a certain part of energy production, right? So what happens in the mitochondria? Absolutely, yep, the Krebs cycle. Krebs cycle happens in the mitochondria, and then the electron transport chain also happens in the mitochondria, which is how you're actually going to generate, the vast majority of your ATP. Red blood cells don't have either of those. They have no nucleus and they have no mitochondria. So their only way to create energy is through glycolysis. We have no Krebs cycle, and in glycolysis we have something called the pentose shunt pathway, which generates NADPH. Okay, so this NADPH is going to allow us to metabolize reactive oxidative species. NADPH is going to allow us to remove some of these reactive oxygen from the red blood cell. It's going to detoxify. It's an antioxidant, right? You know, when you're drinking green tea and you're telling people, hey, I drink it for the antioxidants, I'm trying to be healthy. Antioxidants means getting rid of these things. Reactive oxidative species will damage your hemoglobin. If you damage your hemoglobin, you're not going to be able to carry oxygen. And so, two things that are very important to the red blood cell: glycolysis, which is its only way to generate energy, and the HMP shunt, which allows for the generation of this NADPH, which will delete our reactive oxidative species and keep hemoglobin nice and healthy. Okay? So, when you're talking about G6PD, G6PD is the enzyme that generates NADPH. If you don't have G6PD, you are not going to have healthy hemoglobin. Okay? You need this enzyme to have healthy hemoglobin. Otherwise, ROS is going to come in and destroy it. Okay? If you denature the structure of hemoglobin, hemoglobin cannot carry oxygen. That's a big, big problem. Okay? So that's part 2 of our red blood cells. We have our membrane, we have our enzymes, and so last is we can't really go on without talking about our hemoglobin. Hemoglobin is built up, essentially, it takes an iron molecule, and around that iron molecule, it builds some really sturdy chains. Those sturdy chains, there's 4 of them. 2 of them are going to be alpha chains, 2 of them are going to be beta chains. And when you stick those 4 chains together, you get something called hemoglobin A, which is our adult hemoglobin. Okay? But every hemoglobin will end up having 4 chains. If you, instead of doing 2 alpha and 2 beta, so hemoglobin A is 2 alpha and 2 beta. Okay? If I instead had 2 alpha and 2 gamma, this would be our fetal hemoglobin, HbF. Okay? And so you see, you would have 2 of the same alpha chains in both. The only thing you're changing are these extra 2 chains. Okay, and so you can see on this image here, here's an alpha chain, here's a beta chain, beta chain. If we wanted to turn this from HbA, our adult hemoglobin, into fetal hemoglobin, what we would do is we would change these beta chains into gamma chains, and you would end up with something called fetal hemoglobin. It's very similar to adult hemoglobin. The only difference is it binds onto oxygen a little bit tighter than adult hemoglobin, which is good because if you think about the mother trying to get oxygen to the growing fetus, it needs to deliver that oxygen to the placenta. And so in the placenta, you need to have red blood cells that are really going to grab onto oxygen that's being delivered, grab on tightly, more tightly than the hemoglobin on the other side, so that it will actually cross over and the baby will get oxygen. Okay? So fetal hemoglobin is, when we make fetal hemoglobin, it is typically, while we are fetuses, right? And then as we get older, our fetal hemoglobin will drop and we'll just be left with hemoglobin alpha. Okay, any questions on that? No, great. Hemoglobin carries oxygen, it carries carbon dioxide, and there's this extra thing called 2,3-BPG, which is an O2 modulator. Essentially, 2,3-BPG is going to be a byproduct of glycolysis. Okay, 2,3-BPG is a byproduct of glycolysis. It's made in glycolysis. And when 2,3-BPG levels increase, it makes hemoglobin not want to bind onto oxygen. It makes hemoglobin let go of oxygen. When you increase 2,3-BPG, hemoglobin stops binding onto oxygen. And so while that may not sound like a good thing, right? Like hemoglobin's job is to carry oxygen, why would we want something that makes it let go of oxygen? Well, when you're moving from an area like the heart, you want the oxygen very tightly bound onto the hemoglobin. But once it's left the heart, it's gone through the aorta, it's gone through the subclavian artery, it's gone down the brachial artery, and now it's all the way in our forearm muscle. We don't want the hemoglobin binding tightly to the oxygen anymore. We want the hemoglobin to let go of the oxygen. And so what you'll notice is as red blood cells are moving from the heart all the way into the extremities, 2,3-BPG level will increase. When that increases, oxygen will be released. Okay? And so that's one of the ways that our body makes hemoglobin let go of oxygen. Otherwise, hemoglobin would just go all the way to our fingers with oxygen, hold on to the oxygen, and then just go all the way back to the heart and be like, what? I was supposed to let it go? Oh, I didn't know that, you know? And so we need things in the body to tell hemoglobin, hey, it's okay, you can let go of the oxygen now, it's time to deliver it. Okay, so one of them is BPG. The other one is something called the Haldane effect. Okay, Haldane effect. And so what the Haldane effect is wherever you have a high concentration of carbon dioxide, that makes hemoglobin let go of oxygen. Haldane means when carbon dioxide increases, that makes the hemoglobin let go of oxygen. Okay, so why might this be a good idea? Well, let's think about it. If we have some muscle in our body that's very active, that's doing a lot of metabolism, that's working really hard, it's going to be producing a lot of carbon dioxide. That carbon dioxide is going to start to build up in the area of the muscle. Now we have red blood cells coming in, carrying oxygen, coming into this area with lots of carbon dioxide. What are they going to do when they get there? They see all this carbon dioxide around, what are they going to do? Yeah, absolutely. So they're going to let go of the oxygen and grab onto that carbon dioxide to carry it back to the lungs. That's what you're trying to say, right? Yeah, okay, great. So you're absolutely right. The Haldane effect is wherever there's a high level of carbon dioxide, hemoglobin lets go of oxygen. Okay? Great. Any questions on hemoglobin? No? Okay, great. So one more thing I want to add. We talked about how there's HbA, our adult hemoglobin. 98% of your hemoglobin is going to be adult hemoglobin. Fetal hemoglobin, this is seen in fetuses. There's also something called HbA2. HbA2 is when you have 2 alpha and 2 delta chains. Okay, 2 alpha and 2 delta chains. And typically, the regular adult human being has maybe 1%, 2% of HbA2. However, if you have some sort of problem with hemoglobin synthesis, like sickle cell anemia, Thalassemias, which we're going to talk about, the HbA2 levels increase because the bone marrow is trying to synthesize red blood cells however it can. Even though it's having trouble synthesizing normal hemoglobin, it's going to try and synthesize something to fill up that gap. Okay? Great, so those are our 3 types of hemoglobin, our major types. So whenever we get a question on an anemia, we have 4 questions to answer. Okay, so that we've gotten a question on anemia, and we have to say, okay, how do we approach this? So first we're going to look at breaking it down by the average size of the red blood cell. And what we said before is that the average size of the red blood cell is given by your MCV. MCV is the mean corpuscular volume, essentially just meaning the size of your red blood cell. It's typically going to be anywhere from 80 to 100 is a normal MCV. Anything above that is macrocytic. Anything below that is microcytic. And so that's going to be our first way of differentiating between the anemias. Second thing, we need to look at intrinsic versus extrinsic. Where is this problem coming from? Is it coming from inside the red blood cell? Is something happening outside of the red blood cell? Is the red blood cell being attacked? Is the red blood cell being ruptured somehow? Or is it maybe an enzyme problem from within the red blood cell, like in G6PD? We have an enzyme problem within the red blood cell that's leading to the anemia. So that's question number 2 we have to answer. Number 3. When we have breakdown of red blood cells, in the case of autoimmune hemolytic anemia, in the case of your TTP, your HUS, conditions like this, where is the red blood cell breakdown happening? Is it happening in the vessels? Is it happening, in the vessels of our arms, in the vessels of our body? Or is it happening extravascular? Meaning, is the breakdown happening in the spleen and liver? So whenever you see extravascular hemolysis, this is another term that they never take the time to explain. Extravascular hemolysis means the breakdown of the red blood cells is happening in the spleen or in the liver. And so in cases where you have some sort of autoimmune condition, where you have antibodies binding onto your red blood cells, that hemolysis would be happening in the spleen. Because think about it. As the red blood cell, an antibody binds onto the red blood cell, that red blood cell gets to the spleen. In the spleen, there's tons of macrophages. The entire job of the spleen is to clean out the blood supply. And so when you have an autoimmune hemolytic anemia, typically it's an extravascular hemolysis. We can contrast that with a condition like G6PD. In G6PD, we lack an enzyme that is supposed to be in red blood cells. And so when we have hemolysis, it happens everywhere. The red blood cell doesn't have to wait till it gets to the spleen. You lack that enzyme, so any red blood cell in the entire body can rupture anywhere. So that would be an intravascular hemolysis. It doesn't have to happen in the spleen. We're not waiting for the macrophages to attack red blood cells. We're not waiting for antibodies to bind to them. Instead, it's happening everywhere because every single red blood cell is affected. Okay? Does that make sense? The intra versus extravascular dichotomy there, the difference. We'll go through some examples together too to sort of demonstrate what the difference is, okay? Okay. Great. So that's our intravascular versus extravascular. Extravascular means it happens in the spleen, it happens in the liver. When you have a red blood cell being destroyed, where does it happen? If it happens in the blood supply everywhere in our entire body, we call that intravascular. If it only happens in the spleen or the liver, we call that extravascular. It's just terminology, it's just naming. We're going to see little differences in our lab work if it's intravascular versus extravascular, but otherwise, it's just for you to conceptualize what's happening, okay? If you have some sort of immune attack of your red blood cells, it tends to be within the spleen or liver. If you have instead some systemic problem happening, think about DIC, G6PD, sickle cell. Sickle cell does not have to wait till it gets to the spleen. Cells can sickle anywhere in our blood supply, right? And so these problems are more intravascular because they can happen anywhere. Okay. Last is our reticulocyte count. And so what is a reticulocyte? And why do we worry about how many there are? That's okay. Reticulocytes are baby red blood cells. Baby RBCs. Okay. And so, say you have a patient who's anemic, right? You look at their hemoglobin, it's only 8. The normal hemoglobin is above 10 or 12. You look at their hemoglobin, it's only 8. What do you expect their reticulocyte count to be? Do you expect them to have a high number of baby red blood cells or a low number of baby red blood cells? If they're anemic, what should the body be trying to do? Sure, no problem. So if you have a client who is anemic, their hemoglobin, HB, is, say, their hemoglobin is less than 9. That's anemia, right? If you have hemoglobin is less than 9. So if you see a client or a patient whose hemoglobin is less than 9, when you look at the reticulocyte count, the number of baby red blood cells, do you expect there to be a lot of baby red blood cells or not many baby red blood cells? Many. Exactly, very good. Because the bone marrow should be trying to replace this hemoglobin level. So you should see many baby red blood cells as the bone marrow tries to bring your hemoglobin back up to a normal number. Now, if you have an anemia where there is not many reticulocyte counts, that tells you that there's a problem in making red blood cells. There's a problem there. Because normally the body should be increasing that baby red blood cell count, increasing the reticulocyte count, trying to raise that hemoglobin back up. You know your patient is anemic, the reticulocyte count is low, that means the bone marrow is having trouble making red blood cells. So maybe we're missing something. Maybe we're missing iron. If we don't have iron, we can't make hemoglobin. You can't make hemoglobin, you can't make red blood cells. Maybe there's a problem with some sort of lead toxicity. Lead blocks the entire pathway of making red blood cells. And so whenever your reticulocyte count is low, that means there's a problem making red blood cells. But in all other conditions, you should expect to see an elevated reticulocyte count as the bone marrow tries to restore a normal level of red blood cells or hemoglobin. Okay? Does that make sense? Okay, great. Next. Now, let's move into our different types of anemias. We're going to start off with our microcytic anemia. Okay, if you have a microcytic anemia, meaning your MCV is less than 80, we said that the normal MCV is anywhere from 80 to 100. If your MCV is less than 80, the problem is hemoglobin synthesis. Always. Always. The problem is hemoglobin synthesis. Okay? And so, that can mean you're missing a lot of different things. Maybe you're missing iron. Maybe you have a problem making these chains that we said we need for hemoglobin, right? A problem making your alpha chains. A problem making your beta chains. A problem with the enzymes that are involved with synthesizing those chains. A problem where you have some sort of poisoning leading to blocking of the whole pathway of making hemoglobin. No matter what the problem is, those are all going to lead to a microcytic anemia, and those are all related to making hemoglobin. Okay? Okay, good. So, when we have low iron, what kind of anemia is that? Low iron leads to a microcytic anemia. What do we call that anemia? It's somewhere in this, this picture here. Yes, if you don't have iron, what kind of anemia is that? Iron deficiency. Good. It's our iron deficiency. What about alpha and beta chains? If we're missing those chains from our hemoglobin, what do we call that anemia? Thalassemia. Very good. And so for our HB synthesis enzymes and our lead poisoning, these kind of fall within, they don't really have it listed here, but those are all going to be part of this microcytic anemia picture as well. We call that sideroblastic anemia. Okay, so let's talk about our iron deficiency anemia. Transferrin saturation normally should be at low levels for this iron deficiency anemia. Transferrin is the protein that carries iron in our blood. It transfers ferritin, meaning it transfers iron. When you see transferrin, think about what is the scooter that iron is riding around the body. That scooter is transferrin. If you have low levels of iron, you're going to have low levels of transferrin saturation. Okay? So when you're looking at some of the lab work in a patient with iron deficiency anemia, look for a low transferrin saturation. That's the first thing. Okay? Total iron binding capacity is going to rise. Your capacity to bind iron is increased, meaning there are more spots for iron to bind to because you lack iron. Okay, so TIBC, your ability to bind iron has increased because the body lacks iron. The ability of serum iron proteins to bind iron relative to a normal patient should be increased because we have a reduction in iron. This is iron deficiency anemia. Our overall body store of iron has dropped, and we will see an increased TIBC. What's nice about this is the only anemia that has increased TIBC. This is the only anemia that has an increased TIBC. Everything else, it goes down. Okay, so that's kind of handy and a good way to identify iron deficiency anemia. Iron deficiency anemia is our most common anemia. You're going to see it all the time in your patients, and so it's very, very, very common. Okay. So in the images, what you can see is that we've stained the bone marrow here with a certain stain that looks for iron. And when you stain the bone marrow, what you should see is lots of blue. All of the blue here is iron. And so on the left, you can see in the bone marrow, there's plenty of iron around. On the right, when we use that same stain, we see 0. There is no iron there, and that is pretty consistent with the iron deficiency anemia. And so just to kind of review our iron deficiency anemia, it's caused by a lack of iron. It could be due to chronic blood loss. It could be an increased demand. And so in your pregnant patients, they have more blood volume. However, their hemoglobin does not increase as much as their demand. Dietary lack of iron, especially in developing countries. In the US, we fortify some things like salt with iron, and some other foods are fortified with iron. So you get plenty of iron in the US, but some countries, it's still a struggle to try and get iron. We have a decreased hemoglobin synthesis. Again, any kind of microcytic anemia is going to be due to a decrease in hemoglobin synthesis. So that kind of goes with the name. Some of the symptoms we can see, spoon nails, Plummer-Vinson syndrome. We talked about this when we did our GI chapter, right? Plummer-Vinson syndrome. Something to do with the esophagus. It was a long time ago, right? Not that long ago, maybe a month ago, I think, maybe more. So in Plummer-Vinson syndrome, you have iron deficiency, you have a shiny tongue, and you have an esophageal web. Remember this? It goes all the way around. Liquids can go through, but whenever they eat solids, it gets stuck and it makes them uncomfortable, right? Yeah, exactly. Yep, absolutely. So Plummer-Vinson syndrome, they ask about this a lot. I'm sure you've seen a UWorld question on Plummer-Vinson syndrome at least once because of that connection between iron deficiency and anemia and some sort of GI problem. You know, whenever they can draw these two things together, they love doing that. And so for Plummer-Vinson syndrome, look for that iron deficiency, okay? MCV is low, MCHC is low. This is about the color of your red blood cells. It's, you know, hypochromic, it's missing its color. Reticulocyte count is low. This makes sense, right? If we cannot synthesize hemoglobin, we're not going to be able to make baby red blood cells. So the reticulocyte count should be low, okay? RDW, this is pretty low yield. Don't really need to worry about this, but this is essentially, if you measure from the smallest red blood cell to the biggest red blood cell, what your RDW would be. But again, it's not very helpful for when you're looking at these questions, so I don't recommend wasting time learning about this one. Differential diagnosis, if you see iron deficiency, this is going to be number 1. Anemia of chronic disease, we're going to talk about shortly. Thalassemia minor and sideroblastic anemia. But what we see on iron studies is going to give it away. Number 1, for our serum iron concentration, it's going to be low. It's going to be decreased. Our TIBC, our total iron binding capacity, goes up. The amount of proteins in our bloodstream that have the ability to bind iron is increased because those proteins are not bound to iron. And so the capacity has gone up. Okay. Transferrin, we said, is that protein that carries iron around in the blood. If there's not a lot of iron, the saturation of those proteins is going to be low. Saturation is just the percentage number that have iron bound to it. Okay, just like when we do oxygen saturation, That's the percent of hemoglobin that's bound to oxygen. Transferrin saturation is the amount of transferrin proteins that are bound to iron. Okay. Ferritin is our storage hormone for iron. Ferritin stores iron away in the bone marrow so that it can be used for later. If we do not have iron in our body, our ferritin level is going to be low. Okay, does that make sense? Mm-hmm. Okay, good. Mm-hmm. 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 4 spots, yep. Mm-hmm. Mm-hmm. That's a great question. That's a great question. So in terms of your TIBC, it doesn't have to do with hemoglobin. So, so what it has to do is, I'm going to put our normal over here on the left, and I'm going to put our abnormal here on the right. So let's talk about our normal first. In a normal person, say, you know, I'm a pretty normal person. Besides how I act when I'm tutoring, I'm pretty normal. And so when I eat a nice big meal of spinach, what's going to happen is spinach has a lot of iron. I'm going to absorb that iron into my blood. Now, iron can't just float around in our blood by itself. It needs to be bound to proteins. And so we have proteins in our blood that carry iron. Okay? Let's say I have 5 of these, 6 of these proteins in my blood. I ate a nice big iron-filled meal, and now we have iron bound to some of these proteins. Okay, I'm just going to write Fe for all of these irons. But I didn't eat so much iron that they're all completely bound, right? We only have 4 out of the 6 bound to iron. So my iron binding capacity is 2 out of 6. I have 2 spots to bind more iron, right? So my total iron binding capacity would be 2 out of 6. There's only 2 spots for iron to bind now, right? Only 2 proteins for iron to bind. Does that make sense? The normal? So for our abnormal, we're going to have the same number of proteins, our transferrin proteins, which carry iron in the blood. However, these abnormal patients do not have any iron. They haven't eaten any iron in their diet, or they've had blood loss, and they've lost iron in that way. And so they only have iron bound to 2 of these transferrin molecules. So their ability to bind iron is 4 out of 6. So their total iron binding capacity is going to be 4 out of 6. So who has a higher TIBC? The abnormal, right? Your TIBC increases in iron deficiency because there is more ability for you to bind iron. There's more spots available for transferrin to bind to iron and move through the blood. Okay? So that's our TIBC. Our TIBC increases in iron deficiency. But there's another thing that we talked about before, which is our transferrin saturation. Transferrin saturation. Okay? Transferrin is proteins that carry iron in the blood. For me, after eating all that spinach, my transferrin saturation is I have 4 out of 6 saturated. 4 out of 6 are bound to iron. Okay, so my saturation is going to be 4 out of 6. In an iron deficiency, transferrin saturation would only be 2 out of 6. So their transferrin saturation actually goes down in iron deficiency while the TIBC increases. Okay, but saying all these things, it's great. It's going to help with these arrow questions. The most important thing I'd like you to remember is that TIBC increases in iron deficiency because in all the other anemias we're going to talk about, TIBC does not increase. The only time it increases is in iron deficiency anemia. Okay. Yeah, it is confusing. It is confusing, yeah. I agree. It's kind of weird. So good. I hope that helped. And so those are some of the iron studies that we'll see. We are going to have questions on these iron studies later. So if you continue to have questions, please stop me and ask me, because chances are it's a good question. Sideroblastic anemia. This is a genetic X-linked mutation in a gene that we need to make hemoglobin. ALAS gene is one of the first. ALAS is an enzyme that makes hemoglobin. If we miss that gene, then we're going to have a type of anemia where we can't make hemoglobin. It's going to be microcytic. It can be acquired as well for our alcoholics, lead poisoning, vitamin B6 deficiency, copper deficiency, some drugs like isoniazid. These all will block the ability to make hemoglobin. Okay. And so iron does not get incorporated with the heme molecule, so you cannot make hemoglobin. And so you end up having a lot of iron. Iron is not the problem in this equation. We have plenty of iron in our blood. The problem is we cannot put that iron into our hemoglobin molecule. So we'd said before that a hemoglobin is going to be 4 chains. 1, 2, 3, 4. We'll have alpha, 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 beta, beta. Right? We have 4 chains. And each of those chains needs to have an iron inside. We need to have an iron right there in the middle, and this is what's actually going to bind to the oxygen when we're moving through the blood. In sideroblastic anemia, iron cannot incorporate into these molecules. And so you're going to end up having accumulation of iron around and accumulation of these extra heme proteins around. So what does this look like? On our peripheral smear, if we take a drop of blood from our patient, from their fingertip and then put it under a microscope, we see something called basophilic stippling. Basophilic stippling is what you can see right here. And this is what's present on peripheral smear in sideroblastic anemia. This is really just little bits of hemoglobin that are stuck behind and haven't been incorporated into the red blood cell the way it's supposed to. If you take a sample from the bone marrow, here's where we see our ringed sideroblasts. Okay, and so there's a picture of it here. Essentially what it is erythroblasts, baby red blood cells essentially, with lots of iron accumulation in the mitochondria surrounding the nucleus. We talked about how mature red blood cells, they don't have mitochondria and they don't have nuclei. So these are going to be baby red blood cells. That's one of the first signs that something's abnormal. Is we're going to see all of these baby red blood cells with a bunch of iron accumulating in the cell itself. Okay. However, this is only seen in the bone marrow. Only seen in the bone marrow. In the peripheral smear, we see basophilic stippling. There is a UWorld question that tests you on this exact fact. I don't know how helpful it is for me to tell you about it before you get it, but sideroblastic anemia, basophilic stippling in the periphery. When you take a drop of blood from the finger, this is what you see. If you take a sample from bone marrow, this is what you see. Okay, ring sideroblasts. In terms of our iron studies, iron will be increased. Again, we have plenty of iron. That's not the problem. It's not getting incorporated. A normal to decreased total iron binding capacity. Instead of, we have those 6 molecules that can bind to iron, we're going to have a regular amount of iron. And so 1, 2, 3, 4 of these are going to be bound to iron. We may even have 5 or 6 bound to iron. Because we have all this extra iron, we don't know what to do with it because it's not getting incorporated into our hemoglobin. And so you may even see a drop in your iron binding capacity. If every single one of these molecules is occupied with an iron molecule, you're not able to bind anymore. So your binding capacity is down. Okay. And again, because we have all this extra iron that we don't know what to do with, ferritin is increased. Okay. Last, our treatment for sideroblastic anemia is to give B6. B6 is a cofactor for this enzyme, and so if you have any of this enzyme left in your body anywhere, it's going to increase its activity when you give B6. So it can be helpful there. Okay, questions on this one? No? Okay. Great. So let's just quickly review here. Defect in porphyrin synthesis in the mitochondria. And you can see here, this is kind of hard to read this. I'm sorry about that. But essentially, this is every step going from glycine and succinyl-CoA into a finished heme, a finished hemoglobin. So it's important to know that hemoglobin is made from glycine and succinyl-CoA. You will have a question on this on your step exam. What are the components that make up hemoglobin? You need to know that the most basic things are a glycine amino acid plus succinyl-CoA, which comes from the TCA cycle. Okay? So that's number one. And then you can see ALA synthase. Okay, so right off the bat, this is the enzyme that is going to be mutated in some of our patients with sideroblastic anemia. A lot of the patients have a genetic mutation here in ALA synthase that stop this whole process from going forward. Okay? If instead your problem is lead poisoning, you can see that lead is going to block the process here, and all the way down here is blocked by lead as well. Okay. Some other things that are going to block this process: alcohol will inhibit a lot of these different enzymes, and so alcohol would really stop this from happening as well. And so we said this requires B6 as a cofactor. If we give vitamin B6, we can increase the speed of this enzyme a little bit. If there's any of it left, it's going to help in treating some of this anemia. Okay. Great. So serum iron increased, iron binding capacity decreased, transferrin saturation increased. We have more iron bound to its transfer molecule, and ferritin, the storage molecule, is going to be increased as well. Okay? Great. And so when you download this PDF, take a look at this diagram and really try and get a good idea. It's not that important to know all of these names. This is not terribly important. Especially these ones towards the bottom where there's not even anything written. But some of these conditions, AIP, PCT, CEP, these are all conditions that get asked about. They're called porphyrias, and they often ask about the enzyme deficiency. So PBG deaminase leads to acute intermittent porphyria. UPG decarboxylase leads to porphyria cutanea tarda. And so it's most important, I think, to learn these things. I'm just going to circle them right now. These I'd like you to know. ALA dehydratase is blocked by lead, as well as ferrochelatase is blocked by lead, so know this. And then no ALA synthase, because this is the first enzyme in the whole process. And no glycine and succinyl-CoA are what you need to make hemoglobin. Okay? See, I didn't circle everything, right? You don't have to know everything. Just the stuff that they're going to ask you about. I promise you're going to see questions on this. Okay, great. Okay, so next, thalassemias. Earlier you told me that this is some problem in creating your globin chain. We have decrease in our alpha globin synthesis. For a normal adult hemoglobin, we need 2 alphas and 2 betas. Here, we have a problem with making those alphas, and this is going to give us some sort of anemia. Okay. In our DNA, we actually have 4 functional alpha genes. We have 4 of them. And so when we lose one of them, say we have some sort of deletion and we lose one of these genes, it's not going to cause problems for us. We still have enough genes to transcribe it and turn it into an alpha protein. However, once we start having 2 deletions, this is going to be alpha thalassemia trait. We're going to see some mild anemia. It's going to be there from time to time, and not super severe, but it will be there. If we delete all of our alpha genes, this is called hydrops fatalis. This is lethal in utero. These fetuses usually don't make it to full term. And so what's not here on the diagram, but you can also have 3 deletions where you only have 1 working alpha gene. 1 alpha gene, and that would be our HBH disease. Okay, and so this is going to present with problems. You're going to have some serious problems here. So let's go to the text and see what it says. Alpha gene deletions. If you have 2 deletions, you can have it cis or trans. Cis means that both of the deletions are on the same chromosome. And so you can see here that there are 2 deletions on 1 chromosome. That would be a cis deletion. Trans deletions means they're on opposite chromosomes. And this is more prevalent in African populations. Okay, but they're both the same thing. They both are going to look exactly the same when they present to you. So, 4 alpha genes, if you delete one of them, it's going to be totally asymptomatic. Maybe a little bit of microcytosis. Maybe your MCV. If you look at the MCV is something like 78, 79, really close to that cutoff of 80. So it's a little bit microcytic, but nothing that's going to cause this patient any kind of problems that will bring them into the hospital. If you delete 2 genes, this is going to cause some anemia. We will see a drop in the hemoglobin because of this. 3 genes is going to lead to HBH disease. Here we have excess beta. So all of these extra betas are getting synthesized, but we don't have any alphas. And so what ends up happening is all of the betas form a giant 4-way tetramer, is what it's called, a beta tetramer, which actually precipitates. It forms a little stone inside of our red blood cell, and it's toxic to the red blood cell. Okay, and so this presents with severe hemolytic anemia. Okay, for 4 gene deletion, this is again going to be you're going to have a gamma tetramer, because in the fetus we don't have beta, right? In the fetus, instead, we're supposed to have alphas and gammas. Right? That's our fetal hemoglobin, HbF. So because we are talking about fetuses here, we're talking about the baby in utero, we don't see beta tetramers, we see gamma tetramers. Okay, and so those gamma tetramers are going to precipitate as well and cause hydrops fetalis as well. Okay, questions on this? No. Okay. Does it make sense, sort of how the gene deletions kind of cause this problem? Yes. Yeah, that's true. There is some memorization here, but just keep in mind, the more genes that you delete, the bigger problem you're going to have. So, someone with only 1 deletion is going to be silent. Someone with 2 deletions may have some anemia. Someone with 3 deletions is going to have severe anemia. Someone with 4 deletions is not going to make it to birth. Okay? Great. So, beta thalassemia, we talked about when we have problems with the alphas. Now let's talk about what happens when we have problems with the betas, if we don't have these beta chains. So these are typically due to point mutations in the splice site or promoter sequences, but essentially it's a mutation that causes decrease in beta globin synthesis. Okay, so unlike our alpha thalassemias, an alpha thalassemia, for alpha we have 4 spots, right? We have 1, 2 on one chromosome, and for another chromosome we have another 2. And so that's why we can talk about 1 deletion versus 2 versus 3 versus 4. For beta, instead, we only have 2 genes for beta. We have 1 on one chromosome and 1 on another chromosome. So that means we're going to have beta thalassemia minor, where we have 1 deletion. And we're going to have beta thalassemia major, where we have 2 deletions. Okay, and so that is only the 2 ways to get beta thalassemias. For alpha thal, always remember that alpha thal, there's 4 ways to get it. Beta thal, only 2. And that's because of the number of genes there are to have a mutation in. Okay? So for beta thal, essentially we have an underproduction of beta chain. Usually this is going to be asymptomatic. When we look on electrophoresis, I don't know what the heck happened here, but that's supposed to say HbA2. HbA2 on electrophoresis. And we talked about HbA2 before, and what we said is that most adults have around 2% HbA2. That's for a normal adult, 2% HbA2. When you have a decrease in the amount of beta chains, that means your bone marrow is going to be trying to find something to match up with these alpha chains. So what it's going to find is you're going to have alpha and delta together. Alpha and delta. And that will make a functioning hemoglobin molecule. We call that HbA2. Okay, so when that percent of HbA2 gets to be bigger than 3%, that tells you that there is something going on, and typically that's going to mean that it is an alpha thalassemia. Okay? And so that is our minor. Major means we have 2 deletions. Okay. And so what ends up happening if you delete 2, this means beta chain is going to be absent. You don't have any beta chain at all. So you end up with microcytic hypochromic anemia with target cells, right? We have red blood cells that have a giant target in the middle of them. I know you've seen the pictures of these, what they look like. These target cells are your beta thalassemia. You need to associate those 2 together. These patients are going to need blood transfusions frequently to replace their red blood cells. And because of that, you may see some secondary hemochromatosis. With repeated transfusions, you're going to have buildup of iron. Okay, buildup of iron. Bone marrow is going to start to expand as it's looking for ways to increase the number of red blood cells. This is going to be a crew cut look on skull x-ray, a chipmunk facies, you're going to see changes in the skull bones, and extramedullary hematopoiesis. You're making red blood cells outside of the medulla of the bone. And so we call that extramedullary hematopoiesis, making red blood cells outside of the bone. So where do you make it? You make it in your liver, and you make it in your spleen. And so you're going to have growth of both of those organs. These patients also have an increased risk of parvovirus B19 aplastic crisis, okay, which means they would have 0 red blood cells at all. Okay. So with what I've just told you, do you have any questions? No? Okay, so I have a little question for you. I know you love it when I say that. So we've talked about what the problem is here. We cannot make hemoglobin. So I'd like to know what you think about the different iron studies. So we have our iron level, we have our transferrin. I'm writing TS for transferrin saturation. I'm writing TIBC for total iron binding capacity. And I'm writing our ferritin level for our storage of iron. Okay, and I'd like to know what you think is going to happen to the levels of all of these. And I'm only asking because you know they want to know on step 1 if you know. So first thing, what happens to our overall level of iron? Going up or going down? Going up, good. What about our transferrin saturation? The number of proteins that are bound to iron in the blood. They're going to be up too. I agree 100%. Total iron binding capacity. Right? Yep, you're absolutely right. Total iron binding capacity is low because we can't bind more iron. Okay? And last, what about our ferritin? The storage of iron. Is that up or down? It's going to be increased because we have all that extra iron. We can't add it into our hemoglobin because that's the problem. And so our storage of iron increases, okay? But excellent job on the other 3, okay? These are not easy to do. And so if you can master these 4 for every condition that we do, you are going to be so golden when you take step 1, okay? They love asking these arrow questions. And so this is the extramedullary hematopoiesis we talked about. You can see that the bone of the skull is starting to grow here as the bone marrow is looking for other places to start synthesizing red blood cells. If it's a serious thalassemia, they're going to be dependent on transfusions. Okay, a lot of times the cause of death is going to be cardiac failure due to too much iron being deposited in the cardiac muscle. In our labs, we're going to see decreases in HbA. This makes sense, right? Because we cannot synthesize our normal hemoglobin. We should see increases in our fetal hemoglobin and increases in our HbA2 as our bone marrow tries to make something to carry oxygen. It's going to be making these other things that normally you don't see in adults. Okay, great. And so also basophilic stippling, you can see in the peripheral blood smear as parts of those globin molecules are accumulating, as well as target red blood cells. Okay, great. So for our thalassemias, just kind of comparing them in between the 2, alpha is decreased production of alpha chains. There's going to be 4 types. right? We have asymptomatic all the way through death in utero. Variable signs and symptoms. It's a microcytic type anemia. It can be hypoproliferative, and you definitely want to be able to tell the difference between iron deficiency anemia. And in beta thalassemia, decreased production of beta chain. There's only two types, thalassemia major and thalassemia minor. These tetramers are going to cause hemolysis. We get hair on end on the x-rays. We get hepatosplenomegaly, where the spleen and liver are being turned to make red blood cells. Microcytic and elevated HbA2. Great. So normocytic anemias. Now we are talking about an MCV of 80 to 100. Okay, 80 to 100. And so a decreased number of red blood cells due to decrease in synthesis or increase in destruction. Okay, and so you can see in things like anemia of chronic disease, aplastic anemia, chronic kidney disease. In these cases, you would have decreased synthesis of your red blood cells. So your reticulocyte count would be low. Just like in iron deficiency anemia, we can't make our baby red blood cells, so baby red blood cell count is going to be low. In our hemolytic anemia, we are having something destroying our red blood cells. We can have our membrane defects, like we talked about with hereditary spherocytosis, enzyme deficiencies in G6PD, a problem with the hemoglobin sickling up in the periphery, like sickle cell anemia. Or it can be an extrinsic problem where you're having antibodies attacking your red blood cells, destroying them. You can have things in your bloodstream that are chopping open your red blood cells and releasing all of the contents. And so these are all things that you can look for your hemolytic anemias. But in any case, if it's hemolytic, you're having increased destruction of your red blood cells, that is a normocytic anemia, meaning the MCV is 80 to 100. Red blood cells, mature red blood cells, are of the normal size they should be. That's what MCV normal means, okay? So let's get into it. Anemia of chronic disease. In chronic disease, things like lupus, things like rheumatic arthritis, these diseases that go for a long time, cancer, what ends up happening is you have an increase in your acute phase reactants. One of those acute phase reactants is something called hepcidin. And the biological reason for hepcidin is our body is trying to hide the iron. A lot of bacteria that our bodies have to fight use iron to make different kinds of toxins, to cause infections. And so our body, just through evolution, has developed ways to hide the iron so that bacteria in our bloodstream do not have anything to attack us with. However, when you have a chronic disease, your body doesn't know that. Your body just thinks you have some kind of inflammation going on, and so it's responding in that way. It's increasing hepcidin. It's hiding the iron because it thinks that there's a bacterial infection going on, even though that's not the case. Okay? And so in the iron studies, what you see is that our serum iron, our iron binding capacity, and our transferrin saturation are all going to be low. Why? The iron is sequestered. The iron, we have plenty of iron in our body, but it's all being hidden in the bone marrow. You can see when we stain the bone marrow with this Prussian blue stain, there's plenty of iron here, right? All of this blue is all iron. There's plenty. But because of this hepcidin, we cannot use it. Okay, we cannot use it. One thing that should be elevated is our ferritin. Because all of our iron is being stored away, ferritin is going to be increased. But we're not using the iron to make red blood cells, and so that's leading to anemia. All we're doing is storing it away. And so if we just have some sort of acute bacterial infection, we get some sort of sinus infection, yes, the hepcidin will be going up, yes, we will be storing away iron, but as soon as that sinus infection goes away, all of the iron gets released again. We start making red blood cells again. If you instead have some sort of chronic disease, that is going to mean that hepcidin is going to be high for a long time. And you're going to end up having storage of iron and not using that iron. You're going to end up having anemia. Okay? So in terms of treatment, we need to treat the underlying cause. What is our chronic disease? Treat that. You're going to treat the anemia. You don't want to give these patients a lot of transfusions. The reason is, if you give them a bunch of iron, you're giving them something they already have. They have iron. It's in there. It's just that they have this protein, this acute phase reactant, that's making it so any iron you give to this patient is not going to be used to make red blood cells. It's just going to get stored away in the bone marrow. Okay? And so you have to be very careful with giving these patients a lot of transfusions. Some of the levels we can look for, again, it's going to be caused by inflammation. The MCHC is going to be normocytic. We're going to see hypoproliferative, a low reticulocyte count, because we are hiding the iron away, so we cannot make baby red blood cells. Serum iron, low, it's being hidden away. Iron binding capacity, low, because any proteins that are there are already bound to iron. Transferrin saturation may be low to normal, and ferritin levels are going to be increased. It's going to be stored away. Okay, and so for anemia of chronic disease, remember everything is low except for the storage form, which makes sense when you think about the pathology and how it works. Okay, questions? Okay, great. Next is our aplastic anemia. Here we have some sort of drug, some sort of virus, some sort of chemical, or an autoimmune condition that makes our bone marrow looks like this. This is not normal bone marrow, right? Normal bone marrow has lots of cells in it. It looks very active. You can see baby red blood cells. This bone marrow has failed. This is bone marrow failure. And so we have a destruction of stem cells. No stem cells means no red blood cells, okay? That ends up giving us our anemia. It is normocytic. It's going to have an MCV of 80 to 100. And the reticulocyte count is going to be low, hypoproliferative. Okay. So in terms of therapy, you can give some bone marrow transplant, chemotherapy. When you look at the bone marrow, it's hypocellular. You can see here, all that there is here is just fat cells. And so that's what we end up seeing in aplastic anemia. Okay. Great. Next for our anemias is our paroxysmal nocturnal hemoglobinuria, PNH. Okay, and so your typical patient with PNH is going to come to you and say, Doc, you know, when I wake up in the morning, sometimes I have very, very dark urine. There's a lot, it looks almost red, like I have bloody urine, but it only happens when I wake up first thing in the morning, and it doesn't happen all the time. Okay, and so when we break down this name, that's essentially what it means, right? Paroxysmal means randomly. It means sometimes it happens. Nocturnal. This is like us studying for step 1, nighttime. Hemoglobinuria. Hemoglobin in the urine. Okay, so randomly, you have hemoglobin in the urine at nighttime. That's all this condition is. So now that we know what it is, what causes it? Complement-mediated lysis of red blood cells. Complement-mediated, meaning complement are those factors that typically attack bacteria and destroy bacteria. Instead, complement is destroying our red blood cells. Why is it doing that? Well, we have a factor in our blood that stops complement. In this condition, we lose the anchor that is supposed to anchor that to red blood cells. So red blood cells, you know, normally we have this DAF to protect red blood cells. We lose the anchor for DAF. Now, complement can go destroy our red blood cells. Okay? And so in the labs, we have low haptoglobin. Haptoglobin is a protein. Okay, I'm going to write HP. Haptoglobin is a protein that binds to hemoglobin. Okay, and so whenever you see free hemoglobin, whenever it sees free hemoglobin, it'll bind up that hemoglobin, bring it to the liver so we can get rid of it, right? So normally, you know, if you checked my blood, if you checked your blood, we're healthy people, we should see high levels of haptoglobin. Why? Because it's not bound to anything. We don't have a bunch of extra hemoglobin around. However, once hemoglobin starts to accumulate, it's all going to be binding to haptoglobin. And so what happens is, whenever you have exposure, a lot of hemoglobin in the blood, your haptoglobin level is going to fall. Because it's all bound to hemoglobin. And so when you test for haptoglobin, you're testing for haptoglobin by itself. You're not going to see that because it's all bound to hemoglobin. And so that's the case here when we talk about this complement-mediated red blood cell lysis. It's going to be the case when we talk about hemolytic anemia, When you have hemolysis, that means you're destroying red blood cells. You're going to be releasing hemoglobin. It'll be the case there. Okay. Questions? Sure, no problem. So, essentially, in this condition, I'm just going to make a whiteboard. So here's our red blood cell. This is a healthy red blood cell. It's traveling through the blood, la-di-da-di-da, no problems. Red blood cells have a little protector on them. They have this thing called GPI. And GPI, it protects the red blood cell by attaching to it something called DAF. Okay? Now, how does that protect the blood cell? Now, when complement are those proteins in the blood that are typically supposed to fight bacteria. But really, they're just those angry guys in the bar looking for someone to fight. They're just constantly looking for something to break down. So complement will go around destroying things unless they see this DAF. If complement comes here, they see the DAF, they're going to leave. They're not going to break down the red blood cell. Now, that's for our normal patients. For our patients with PNH, what happens is, here's your red blood cell, here's your DAF. There is nothing attaching the DAF to the red blood cell. You lost your GPI anchor. And so because the DAF is not bound to the red blood cell, DAF is just going to go on its own separate way. Red blood cell is going to go on its own separate way. And guess what? This drunk guy at the bar is going to find the red blood cell, and it's going to destroy the red blood cell. Okay? I should say complement. Okay? And so in PAH, the problem is you don't have this anchor for DAF. DAF does not protect the red blood cell anymore from complement. Okay? So that is essentially the idea behind this disorder. The idea behind haptoglobin is essentially that haptoglobin is a protein that binds to free hemoglobin. If there's no free hemoglobin level around, haptoglobin should be normal. If you start to have breakdown of red blood cells, hemoglobin will be released into the blood, haptoglobin will bind to that hemoglobin, and your haptoglobin level will fall. Okay? So, why does it happen at night? We have the whole, taking up center stage in here is this whole nocturnal thing. And so the reason for this is because when you are sleeping, your respiratory rate starts to fall. You breathe slower when you're sleeping, okay? As your respiratory rate starts to fall, the amount of carbon dioxide in your blood is going to increase. Increased carbon dioxide means a decrease in pH. Now, this is not some sort of horrible acidosis that is going on in your body every single night. It's a drop of pH of maybe 0.3, 0.4, just a slight drop in the pH. But whenever you drop pH, you're going to go piss off that drunk guy in the bar. You're going to make complement more active. And complement is going to be more active looking for things to break down. So when you increase the carbon dioxide, you're going to drop the pH, you're going to have an increase in your complement. Increase in your complement means you're going to have increase in your breakdown of red blood cells, which is why it happens at night. Okie dokie? Great. So again, the important thing for you to know of PNH is this loss of GPI anchored proteins. You got to know this one, okay? The GPI anchor is going to be what anchors your DAF, which is AKA CD55. So, this is what's missing from your red blood cells. Because you can't anchor it with GPI, you're not going to have this CD55. Okay? Good. So, just a quick review. Paroxysmal nocturnal hemoglobinuria. It can be acquired or it can be genetic. A loss of this anchoring protein means you're going to have lysis of your red blood cells due to complement, a decrease in your haptoglobin, and you are at risk for venous thrombosis. We see a normocytic anemia, and your reticulocyte count is increased. Your bone marrow is still doing what it's supposed to be doing. Bone marrow knows how to make baby red blood cells. It sees that red blood cell levels are falling, and it responds in kind by increasing levels of baby red blood cells. Okay. And so you can see here some sort of stimulus. This could be a drop in the pH, for example. That is going to turn on your complement pathway, turns on this membrane attacks complex, and then that is going to destroy your red blood cell, leading to intravascular hemolysis and hemoglobin in the urine. Okay. Questions on this one? So in this one we can do it. Yeah, let's do the iron test. That's a good question. So iron, transferrin saturation, our total iron binding capacity, and our ferritin. Okay. So for our iron, iron's going to be increased, decreased, or normal? Normal. Good. Transferrin saturation, increase, decrease, or normal? Normal, yeah. How about TIBC? This would be normal too, yeah. And ferritin, our storage of iron. This could be normal or decreased. And the only reason I say decreased is because we're going to be using some of that storage to make those new reticulocytes. Right? We're going into that storage of iron in order to make some of these new red blood cells, and so we may need to go into some of those, into the pantry and grab some more iron molecules to make those. Okay. Good question. Okay, good. So we talked about paroxysmal nocturnal hemoglobinuria. You're having breakdown of red blood cells. Now we're going to talk about hemolytic anemias. Here we have some sort of red blood cell breakdown. There's a number of ways you can get it. Some sort of red blood cell abnormality, paroxysmal nocturnal hemoglobinuria, or an extrinsic abnormality, meaning antibodies are attacking our red blood cells. We're having mechanical destruction. Something is going up and ripping up our red blood cells. Or an infection, like malaria. In malaria, you have a parasite that goes into our red blood cells and pops them open. Okay? And so, in all of these cases, these are what we call hemolytic anemia. We have destruction of our red blood cell. It's either an antibody, it's the red blood cell banging into something and opening up, or it's an infection. Okay? So, intravascular hemolysis versus extravascular. What's the difference between intravascular and extravascular? Excellent. Very good. Excellent. Very good. And so, I'm so glad you told me that, because now I can talk about why we even care. Why do we care where the red blood cells break up? Because if your red blood cells are breaking up in the spleen, the spleen is an organ that's built to handle red blood cells breaking up. That's the whole point of the spleen, is to clean the red blood cells out of the blood. If you have old red blood cells, you have red blood cells that they're not shaped right, they're missing enzymes, they're missing hemoglobin. The spleen is built to handle that. Okay? This is like when you have a problem with your car and then you take it to the mechanic, right? The mechanic can put the car up on the lift, it can handle all the spills of oil, you're not going to see anything around, right? It's perfectly built to handle that. Intravascular hemolysis means it's happening anywhere. And so anything that ruptures that red blood cell, all the things from inside of the red blood cell are just going to be released into the area. Okay, and so if you're releasing hemoglobin into the area, wow, that's going to cause a drop in your haptoglobin. If you're releasing the enzymes, now you're going to have things like LDH, which is an enzyme in red blood cells. LDH levels are going to increase because we're not getting rid of those enzymes. We're just popping our red blood cells and leaving it there. This is like when you try and change your oil in your own driveway. Most people's driveways are not built to handle changing oil. And so you're going to have oil spilled everywhere. You're going to have tools spread out all over the yard. We're not really built to handle that. Unlike at the mechanic shop, unlike at the spleen, where we're built to handle breaking down red blood cells, and you're not going to see all those changes in haptoglobin and hemoglobin in the urine, hemosiderin in the urine. You won't even see swelling of the spleen if it's intravascular. For extravascular, you will see swelling of the spleen because that's where all the magic is happening, right? Does this make sense? The difference between them, why that's kind of important in terms of lab work? No problem. So, let me just make a quick whiteboard. So, here is our spleen, okay? And here is our vessels, okay? And so, you know, this is going to be our intravascular. This is intra. This is extra. In both cases, we're talking about red blood cells being destroyed, right? We're just talking about where that's happening. And so if a red blood cell comes into the spleen, and now the red blood cell gets destroyed, everything that was inside of the red blood cell, the hemoglobin, any kinds of enzymes like LDH, all those things are going to be released into the spleen. The spleen can handle that, and so it's going to get rid of the hemoglobin, it's going to get rid of these extra enzymes, and so the blood that leaves the spleen is not going to have all of these breakdown products inside of it. The spleen itself can handle breakdown products from red blood cells. Compare that to if we're just in the vasculature. If we're just in some random vessel, right, we took the left turn down the brachial artery and now we're in the ulnar artery, the red blood cell now gets to this point and all of a sudden, boom, it gets destroyed. Now, where you are releasing into the blood, all of that hemoglobin is going to be going into the blood. All of that LDH is going to be going into the blood. And so when we look at our lab work, what we're going to see is an increase in our LDH level. Okay? Because hemoglobin is out here, hemoglobin is going to bind to haptoglobin. We're going to see hemoglobin bound to haptoglobin. So when we check our haptoglobin levels are going to be down, because all of the haptoglobin is bound to hemoglobin. If we look at our patient's urine, we're going to see hemoglobin, hemoglobinuria. Meaning we're going to see hemoglobin in the urine because we just released this hemoglobin right into the blood. What if this blood is going to the kidney? Now that hemoglobin is going to cross over into the nephron and leave via the urine. And so the difference between intravascular and extravascular is that when you break down your red blood cell in the periphery, you're breaking it down in an area where all of the breakdown products can just be free and go into the blood. Versus if you break down that red blood cell in the spleen's going to get rid of that extra hemoglobin, it's going to get rid of that LDH, and so you are not going to see LDH. Haptoglobin levels are going to be normal. You're not going to see hemoglobinuria. It's just going to be essentially a swelling of the size of the spleen as it's trying to accommodate for all these extra red blood cells. Okay, does that make sense? Mm-hmm. 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 That's a great, yeah. Yeah, that's a great question. And so, mhm. Mhm. Excellent question. So first thing you're going to see is that your patient is anemic. You're going to see they're anemic, and then you'll look at the iron levels. Everything is normal. The concentration of iron is normal. Iron binding capacity is normal. Transferrin is normal. Ferritin is, everything's normal. Okay? Then you're going to look at the reticulocyte, and you're going to see the reticulocyte count is increased. So you see low hemoglobin, which is your anemia, and you see an increase in your reticulocyte count. That should mean to you that you're making your red blood cells, but something is destroying your red blood cells. Okay, so now you're thinking about, okay, I think it is a hemolytic anemia. I think I'm making red blood cells and something is destroying it, but I don't know if it's an intravascular hemolytic anemia or extravascular. So now I'm going to look at these things. I'm going to look for LDH, haptoglobin, and hemoglobin in the urine. If I don't see those, boom, I have my answer. It has to be extravascular hemolysis, because that is the only thing that will explain everything else that we saw. We saw, an anemia that's normocytic, 80 to 100 MCV. We saw normal iron studies. We saw an increased reticulocyte count. And then we didn't see LDH, we didn't see a change in haptoglobin, and we didn't see hemoglobin in the urine. So that the only explanation for that is that red blood cells are showing up in this kidney and then they're never leaving, right? You check in, but you don't check out. We're going to go back to our patient, we're going to press on their belly, and boom, we are going to feel a swollen spleen. Okay? So, essentially, you got to do a lot of testing to answer your question. You got to really rule other things out. As we talk about our different causes of extravascular hemolysis, you will see that depending on the cause, there are sometimes a specific antibody you can test for. An antibody against a red blood cell, for example, is something that you could test for. If you saw that, you would know it's extravascular, because the way that works is your red blood cell, let me just get rid of some of this chicken scratch here. What's going to happen is your red blood cell, when your red blood cell gets to the, here's your little red blood cell, it's got an antibody bound to it. Okay, and so while it's in the blood vessel, nothing really happens. It just hangs out with that antibody bound to it. Nothing really happens. It's just going to keep going through the blood. Now this red blood cell is finally at the spleen. It's going to enter the spleen, and then the spleen is going to take one look at this guy and be like, whoa, whoa, whoa. What the heck is that thing sticking out of your ear? Right? Why do you have this thing hanging off the side of your face? What is that? No, you're not going any further. I'm destroying you right here. And so if we have an antibody that's binding to red blood cells, that is one quick way to test for what is the diagnosis. Okay? Otherwise, you have to do a lot of testing to figure it out. Okay, great. So, great. And we've talked about all this. Our red blood cells are phagocytosed by the macrophages in the spleen and liver, and that's why we don't see any of those breakdown products. So, first condition we're going to talk about, hereditary spherocytosis. Here, we have some sort of deficiency in those membrane proteins we talked about. We talked about how you need that cytoskeleton to make red blood cells nice and flexible. As they're moving through the blood, they don't rupture because they're easy come, easy go, very, very flexible, very chill guys, right? If you take away those membrane proteins, you're going to end up with blood cells that are perfectly circular. They're like a sphere, and they're very taut. They're very tight, right? It's like when you blow up a balloon, you're blowing up a balloon, and then it gets to a point where you can't blow anymore, and then you blow a couple times more, and we feel that balloon. It feels like it can pop in any second. That's the way our red blood cells are now. So when this red blood cell is in our vessel, it is going to hit this fork in the road, and it is going to pop like a water balloon, okay? Very easily pops open. And so we will see some intravascular hemolysis. You're going to see a drop in your haptoglobin. Okay, that's number one. Number two is when that red blood cell that's very circular gets to the spleen. When it gets to the spleen is going to look at this thing and say, whoa, 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 this is not a normal looking red blood cell. It's going to get destroyed in the spleen as well. So you're going to see intravascular and extravascular hemolysis. You're going to see both. You're going to have a swollen spleen, and you're going to have LDH and decreased haptoglobin and all those sorts of things. Okay. One thing that can actually help these patients is to take their spleen out. That prevents destruction of our red blood cells inside of the spleen, and so you're just left with the red blood cells that are breaking down in the periphery. And typically, your patient is not going to have as many problems if you do that. Okay. Great. So we can read through here. Splenic hemolysis of rigid red blood cells. We get hemolysis in splenomegaly. and a hyperproliferative reticulocyte count as it tries to restore the normal amounts of red blood cells. Now, the specific testing we have to talk about here, it's called osmotic fragility. Osmotic fragility. So what this is saying is that, when we talk about our normal red blood cells, they're kind of like shaped like that tube when you go tubing down the river. And so they can take up a lot of water. If you put water into this red blood cell, what's going to happen is it's going to stretch a little bit. It's going to start to be shaped like this. Okay? So it's going to go from this size to this size as it takes water. If you talk about a spherocyte, okay, so here's our normal spherocyte. It is full. It is taut like a balloon. And then you try and get that spherocyte to take up water, what's going to happen? It's going to pop. It's going to blow up. Yes. Just like in the summer when we throw water balloons at our little brothers. Same thing is going to happen. And so that is what our osmotic fragility test is. And so here's our osmotic fragility test. On the bottom here, you can see the concentration of sodium. On the y-axis, we see percent lysis of red blood cells. Okay? And so before we look at this chart, actually, I'd like to just kind of draw it out for you. Okay? So here is the concentration of sodium. As we move to the right, there's more sodium. And on the y-axis, we have percent of red blood cells that are dead. Okay? We're trying to kill all the red blood cells. And so normally, when we put our red blood cell, I'm going to do normal in blue here. When we put a normal red blood cell into more hypotonic fluid, if we put a red blood cell into water, what happens is as the solution gets closer to pure water, red blood cells are going to start to pop. That's just normal. Red blood cells are going to pop, and as we get closer and closer to normal water, eventually all of the red blood cells are going to pop. And this is for a normal patient. Your red blood cell, as you're getting into more dilute water, it's going from this size, it's getting a little bit fatter, it's going to get a little bit fatter, and then eventually it's going to pop, okay? And so that's for our normal red blood cells. As you get into less and less concentration of sodium, you get closer to popping. Now, for our very taut spherocytes, what's going to happen is as you are introducing these spherocytes to a more hypotonic solution, they're going to pop earlier. Okay, and so the number of red blood cells that are dead is going to start to increase much earlier than our red blood cells that are normal. Okay, and so as we're moving our spherocyte from, say, this is 2% saline, this is 1% saline, this is 0.5% saline, and this is just pure water, is when it pops. For our spherocytes, these are going to pop already. All right, so these are actually popping when we're moving from 2% to 1% saline. Does that make sense why I'm saying that they pop earlier as you move this way? Yeah? Okay, great. And so if we look at the official chart here, I'm going to remove my chicken scratch. What you can see is here is our concentration of saline. Here is the percent lysis, the number of dead red blood cells for our normal red blood cells. When you get to 0.5 is when they start to pop, and they finish popping when you get down to about 0.3. Okay, 0.3 is when you have about 100%. For our spherocytes, they start popping at 0.7. Okay, so they've already started popping, and they continue popping much earlier than our regular red blood cells. And this is what we call our osmotic fragility test. What you're going to see on your step one is a chart that looks like this. You're going to have one line that looks like this. You're going to have another line that looks like this. And they're going to say, hey, which one is for the spherocytes? Okay, and you're going to be like, oh my God, I know Aaron explained this at one point, and I just want you to remember that these are fragile. You're moving from right to left, so since they're fragile, they pop earlier. This is going to be your spherocytes. This is your normal red blood cells. Okay? Great. Okay, and so what else can we say here? Spherocytes, they're smaller than normal red blood cells. You can see that they don't really have that central pallor inside. They're just completely round looking. There's another one here, another one here, another one here. These are our spherocytes. They look like little spheres. Okay. Any questions on our spherocytosis? If you're asked, what is the treatment for this? Say splenectomy. Take out the spleen, and these patients are going to be okay. All right, great. Great. So, autoimmune hemolytic anemia. Here we have our body is making an antibody that is attacking our red blood cells, an autoimmune destruction of red blood cells. And so there's two types. We have warm hemolytic anemia and cold hemolytic anemia. Our warm hemolytic anemia involves IgGs. And so this is the red blood cell that has the antibody bound to it, which is an IgG. It shows up at the spleen, and the spleen is like, what is that thing hanging off of your face? No, you're dead. That's it. Okay, so it's an extravascular hemolysis. It's associated with lupus. It's associated with leukemia. It's associated with certain kinds of drugs like penicillin and methyl-dopa. And again, the IgG is going to present red blood cells to macrophages inside of the spleen, causing that. You may see some spherocytes on peripheral smear, just because as these antibodies are binding to the red blood cells, they kind of change the shape of the red blood cell. In terms of diagnosis, we can do something called the Coombs test. Okay, and the Coombs test is where we take a little bit of our patient's red blood cells. Okay, and so we're going to take their red blood cells. Their red blood cells have antibodies bound to them. And what we're going to do is we're going to add into this an antibody against antibodies. Okay, and so we're going to add in our own. I'm going to change the color here to yellow. We're going to add in our own antibodies, and these only bind to antibodies. And so a positive Coombs test means that the antibodies that we added, these yellow antibodies, are binding to something. And all that we took from our patient is red blood cells. So that means if the antibodies are binding to antibodies, those other antibodies must be bound to red blood cells. And so this is a Coombs test positive. Coombs test positive is warm hemolytic anemia. Okay. Cold hemolytic anemia is going to be either your intracellular or extracellular. It can happen in the vessels. It can happen in the spleen as well. This is usually going to be post-viral upper respiratory tract infection. Think about your Mycoplasma pneumoniae. They can present with this. Autoantibody to red blood cells is produced while fighting the upper respiratory tract infection on accident. Okay. However, the patient is asymptomatic unless exposed to cold temperatures. And so they're not going to have the anemia unless they go outside into the cold air. And that cold air is going to hit their red blood cells that are in their fingers and toes and start hemolysis happening. Okay. So on peripheral smear, what you're going to see is this agglutination, meaning your red blood cells are going to be clumping together. Because we have an antibody binding to the red blood cell here, the Coombs is going to be positive as well. Okay, and so the way to remember that one is intravascular and one is extravascular. Extravascular happens in the spleen. Spleen's in the middle of the body. The middle of the body is pretty warm. Okay, and so that's your warm IgG. Cold IgM can happen at the periphery in your fingers where things are cold, or in the middle. Okay, so cold, think about it happens in the periphery. Warm, it happens in the spleen. And that will be your kind of helpful way to remember that one. Okay, great. Any questions on autoimmune hemolytic anemia? No? Okay. Some more hemolytic anemias we can talk about here. Microangiopathic hemolytic anemia. Essentially what we're saying here is that there's some sort of destruction of red blood cells happening that's a mechanical destruction. Something is actually going and chopping our red blood cells open. So what could that be? Well, in DIC, disseminated intravascular coagulation, you're going to have clots. Those clots are going to be breaking the red blood cells. If we have a vessel here, you have a red blood cell, and then you have a clot that's formed on the wall. As this red blood cell tries to move by, the clot is going to tear this red blood cell open. And so on this side of the clot, your red blood cell is going to look something like this. And so when you have hundreds and thousands of red blood cells going past this clot, eventually you're going to end up with an anemia because you're destroying all of your red blood cells. Look at this schistocyte. Schistocyte means that it's been mechanically destroyed. And so that's what we see in DIC. TTP, we're going to talk about in one of the upcoming slides. HUS, we're going to talk about, but both of them qualify as microangiopathic. We have some mechanical destruction of red blood cells. Other causes, heart valve. If you have a mechanical heart valve or if you have aortic stenosis, that can chop up the red blood cells as they go by. Malignant hypertension can cause this as well. And because this is happening in the vessels, low haptoglobin, increased LDH is what you should expect to see. Okay. Another type of hemolytic anemia, some sort of infection. So malaria, babesia, all of these different parasites that are transmitted by mosquitoes. You can look at the peripheral smear and usually you can see the little parasite inside of a red blood cell. It's going to have intravascular hemolysis as they multiply and divide and pop the red blood cells open to release their babies, and extravascular as the spleen is destroying anything that looks weird. If this red blood cell goes to the spleen is going to say, whoa, 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 what is that weird looking thing on your face? No, I'm destroying you. Okay, so for infections, we have intra and extravascular. For our MAHAs, our microangiopathic hemolytic anemias, these are all going to be intravascular. So expect to see low haptoglobin and increased LDH. One of the hemolytic anemias that we can see, destruction of red blood cells, is our G6PD deficiency. Classic one to talk about, right? In G6PD, we lack a certain enzyme. That means we can't make NADPH. Earlier, we talked about how important NADPH is to detoxify our hemoglobin. NADPH is going to make glutathione. Glutathione is going to protect hemoglobin from reactive oxidative species. If we can't make NADPH, our hemoglobin is going to be destroyed. It's going to be denatured. You can see these Heinz bodies are essentially just clumps of denatured hemoglobin inside of a G6PD cell. Okay, and so typically there's going to be some sort of trigger that starts this infection. So or that starts this hemolysis. So some sort of medication, antibiotics, antimalarials, sulfa drugs. If your patient eats some fava beans, that can sometimes be enough to trigger this inflammation. And so that's sort of, you're going to see some history where it kind of came out of nowhere. Your patient started a new medication, now all of a sudden they're anemic. What happened? You look at their blood and you see tons of, low haptoglobin as well as tons of LDH, increase in LDH. You're going to see hemoglobinuria. I'm just writing HU for hemoglobinuria. And so these are the things you're going to see because it's intravascular. It's happening everywhere. You'll also have extravascular as, whenever these red blood cells are showing up at the spleen is going to say, whoa, 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 what are these little clump things? You know what? You look okay. I'm just going to kind of take a bite out of you and send you on your way. And so you end up seeing these bite cells on peripheral smear where the spleen actually took a bite out of the red blood cell to remove that little clump. And so the red blood cells, they're still basically functioning. They just kind of, they're just kind of missing a little bit, right? So macrophages are going to bite the plasma membrane, and so that's what we can see there. Okay, great. And so abnormal hemoglobin, we kind of talked through this already. Our HbA2 is beta chains, A2 is our delta chains, fetal hemoglobin is gamma chains, and I'm not really sure what this slide is doing here. This probably should have been earlier. Note to self, move slide. Okay, great. But just sort of another for you to see, fetal hemoglobin has got that gamma chain. Great. So sickle cell anemia, here we have polymerization of our hemoglobin. Instead of making regular hemoglobin A, we make hemoglobin S. And the problem with hemoglobin S is that any time you have some sort of stress to the red blood cell, it's going to turn into a sickle. It's going to go from this nice shape of a regular red blood cell into a sickle shape, like this. Okay? Sickle shapes are not going to be able to move through our vessels easily. They're going to essentially accumulate and then ultimately obstruct the red blood cell obstruct the vessel so that nothing can pass through. Okay, they're going to completely, almost like clotting up that vessel, and so this is what's going to cause all your patients' problems. Anything that increases the polymerization, things like dehydration, fever, infection, and acidic pH, drop in your oxygen tension. If you have someone with sickle cell that goes to a very high elevation, say they went hiking with you this weekend, that would cause them to start sickling as well. Okay, and so what happens when they sickle? They get these things called vaso-occlusive crisis, where they have occlusion of some of the small blood vessels. This is going to cause pain in their lungs, pain in their abdomen. It can lead to stroke, ischemia, and infarction of the heart. Very, very, very difficult problem to deal with for these patients. Okay. If they get an infection with parvo, this is going to make it even worse, as they'll stop making red blood cells altogether. Okay. Great. So on peripheral smear, look for sickle cells, Howell-Jolly bodies, which are dark spots of DNA inside of red blood cells. On the lab, you can do electrophoresis to find sickle cell hemoglobin. And therapy actually is something called hydroxyurea. If you give a patient with sickle cell anemia hydroxyurea, it's going to increase their level of fetal hemoglobin. They go from trying to make HbS to making HbF. HbF is our fetal hemoglobin. It's got those 2 gamma chains on it, and it is perfectly fine for people to have higher levels of fetal hemoglobin in their blood supply. There's not really a big problem there. It's definitely better than their screwed up hemoglobin they currently have. Okay? Great. And so what often happens with these patients is they do something called autosplenectomy, where they actually, because of all of the occlusions that happen in their spleen actually shrinks down and dies. Where by the age of 15, most patients with sickle cell anemia will not have a functioning spleen anymore. Okay. And the last thing I want to say here about sickle cell anemia is this mutation in the beta chain, where it's a valine to glutamine mutation, is actually very important. This is something that they ask about. Okay. Valine to glutamine. Okay. Okay. Hemoglobin C is a bit like sickle cell anemia, where you're making a type of hemoglobin that doesn't work. You can see here in the peripheral smear that the hemoglobin is sort of collecting into a crystal. We call these HBC crystals. It's much less common and not something you'll have a ton of questions about, but it is something to be aware of because these clumps are very big. And so when we do our electrophoresis, we're going to be able to point that out. And so speaking of electrophoresis, what exactly is electrophoresis? How does it work? So essentially what you have is you have a gel panel. And in this gel, you have an electrode on one side and an electrode on the other. What you're going to do is you're going to put proteins on one side of this panel. They're going to move from the negative charge towards the positive charge. Proteins are negatively charged, right? All proteins have a negative charge. So they want to get away from this negative and they want to move towards the positive. So every single protein you put on this panel is going to want to get all the way here to the positive. But the thing that is going to dictate whether or not they get all the way over here is the size. If it's a very big protein, it's not going to be able to travel that far. If it's a smaller protein, if it's a nicely made, beautiful protein that has no problems with it, it'll be able to go pretty far. So you can see for our normal adult hemoglobin, it goes pretty far, right? It started all the way here at the origin. There's a negative charge over here. It moved away from the negative charge and it almost made it all the way to the positive charge. Not quite, but it got pretty close. Okay, so that's our normal adult hemoglobin. Let's look at our fetal hemoglobin. So fetal hemoglobin is going to have one regular alpha chain and one of those gamma chains. And so what we end up seeing is we have 2 stripes on the hemoglobin electrophoresis. We have one stripe for the alpha chain, one stripe for the gamma chain. The gamma chain is a little bit bigger, it's a little bit bulkier, and what we see is it doesn't go as far. Okay, so it tried to make it all the way to the anode, but since it's a little bit bigger, it couldn't quite get all the way. This is as far as it got. Let's look at our sickle cell trait. In sickle cell, for sickle cell trait, we have one normal alpha chain and then one disease chain. Okay, and so what do you expect to see on this panel? Are you going to see one line or two lines? Two lines, good. And because that sickle cell hemoglobin is a little bit bigger, a little bit bulkier, it's not the correct shape, it's not going to get that far on the panel. And so you can see with the one normal hemoglobin, we have it all the way here close to the anode. This is the cathode because it's positive. It's getting almost there, but not quite making it. And then you have the sickle cell part. This is a big, bulky, sort of doesn't have the right shape. It kind of clumps its way along and makes it about halfway through the entire plate. Okay, so that's for sickle cell trait. Now, if we have sickle cell disease, that means we have no more normal hemoglobin. All we have is abnormal hemoglobin. And so for this panel here, do you expect to see one line or two lines? One, exactly, very good. So all of the hemoglobin is not going to make it very far on the panel. It's not going to make it anywhere near as far as the normal hemoglobin. It's not going to make it anywhere near as far as the fetal hemoglobin. It's just going to kind of clump along right to this point and not move any further than that. Okay, for our HBC we talked about, HBC trait, we're going to have one normal hemoglobin and then the C. And the C this is the one that forms crystals. And so this is a very big, bulky, heavy hemoglobin molecule. And so what we end up seeing is we'll have one line for our normal hemoglobin. For the C trait, we're going to see this is not even making it halfway, right? This is a big, bulky molecule. And so even though it's trying to make it to this positive side, it can't make it. It is too big and bulky. Okay. For our C disease, here we're going to have one line, and they're both going to be of that abnormal hemoglobin. And then there's also something called HB sickle C disease, where one of their hemoglobin molecules is a sickle, one of theirs is a C. I know probably the most unlucky people that are around, because how did you end up with two mutations that are totally different? And so do we see one line here or two lines? Very good. Yes, we'll see one line for that sickle cell, one line for HBC. Okay, very good. And so now we can kind of put all of this theory into practice. We have a negative anode here and a positive anode here. So, and then all of our lines of hemoglobin along these panels. So are the hemoglobins moving this direction? Are they moving up or are they moving down? Which way are they coming from? Which way are they going to? Going up. They are going up. They're moving away from the negative and towards the positive. And so we said that our hemoglobin A, our regular adult hemoglobin, is going to be the lightest and the easiest to travel along. And so if you're looking at all of these different wells, you can see they're all numbered 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Which of those do you think would represent a normal adult hemoglobin? 1 and 2. Yeah, excellent. 1 and 2. They both have one line, and that line is sort of the farthest line that you can really see on here. Okay, and so good. So number 1, number 2 are both going to be normal adult hemoglobin. On number 3, we can see we have one line of normal adult hemoglobin, and then one line that's close but doesn't quite get there. So what might this hemoglobin be? It's okay if you're not sure. Fetal, excellent. Yeah, so on fetal hemoglobin, we have our alpha chain and then we have our gamma chain. Our alpha chain is going to be traveling all the way to the end. Gamma chain's a little bit bigger, so it tries to get there but doesn't quite make it. You're absolutely right. This is going to be our HbF, fetal hemoglobin. Good, okay. And so now, looking at the rest of these wells, we've already identified what this line is. No matter which well we look at, this is always going to be our HbA, right? The second well is always going to be that gamma chain. Okay, and so we really only have two other options. We can see that there's another line that makes it almost halfway through the whole panel, and then another line that must be pretty big and bulky because it barely makes it away from this negative anode. And so we need to figure out which line is which. So for our well number 4, what do you think that this hemoglobin could be? Sickle, good. Is it sickle cell disease or sickle cell trait? Good, very good. We have one normal and one abnormal, so it must be our sickle cell trait. We have one S and one A. Good. And I don't see any well that only has this, and so probably there's no sickle cell disease on this, okay? Last one we need to identify is going to be this one, where we have this line down here and this line all the way at the top. What are you thinking for this one? Hemoglobin C, good. Disease or trait? Trait, very good. So this is going to be C and A. And then last, in this well number 11, what do you think is happening here? This one looks pretty abnormal. I love it. Yes, sickle cell plus C. And so you can see HbF and HbC all the way down here. Okay. Very good. Any questions on this one? No? Great. Okay. So now, I will send you this PowerPoint so you can kind of go through this on your own. I'm not going to, make you answer all of these up and down arrows at, 9:24 at night. I feel like that's a bit mean, but I'm going to send you this slide, at least for the PowerPoint, so that you can actually click through and add these arrows for yourself. Okay, I want you to mentally do it first, or actually even draw on it. Yeah, right? That I was going to make you do it, right? I'm not going to do that to you. That's just too mean. So do this, draw it out, make the little chart on a piece of paper, and then draw it for yourself. So that way you are comfortable with these, because you and I both know these are questions on your step 1 exam, 100%. You know they're going to ask you these up and down arrows, and you're going to have to answer it. So, so know it now. Don't have any questions in your mind now, so that way it's comfortable for later. Okay, great. We talked about our microcytic. We talked about our normocytic. Now we're going to talk about our macrocytic or megaloblastic anemias. There's really just two to talk about: our vitamin B12 deficiency and our folate deficiency. And so that makes life a little bit easier, right? There's just two that we need to know. And so in both of these cases, if you miss vitamin B12 or you miss folate, what happens is you can't synthesize your DNA that you need for your red blood cells. Can't make DNA, can't make your red blood cells, so you're going to end up with anemia. And so we get a macrocytic anemia, hypoproliferative, low reticulocyte count, because we cannot, if you can't make the DNA, you can't make baby red blood cells either, and impaired DNA synthesis. And so what you end up seeing on peripheral smear down here is these macroovulocytes, really big red blood cells, and hypersegmented neutrophils. And so this is a little bit harder to see in this lower image, but if you look at this cell right here, normally your neutrophils are going to look something like this. Right, that's kind of like what a neutrophil looks like. In megaloblastic anemia, you get hypersegmented neutrophils. So instead, you end up with something like this. If I can draw it out, you end up with a lot of segments. Okay, rather than just having one or two segments, it looks like it has a lot of segments. That's not a great drawing, but this is definitely something that you need to know. If you see these words together, hypersegmented neutrophils, think about megaloblastic anemia, think about your vitamin B12 or folate deficiency, okay? Because they're trying to hand you the answer at that point if they're putting those words in the question. So either deficiency of vitamin B12 or folate will both give you this inability to synthesize DNA and megaloblastic anemia. But B12 deficiency gives you something a little bit extra on top of that. So what happens when you have B12 deficiency? What else do you have besides anemia? Very good. Yep. So paresthesias, sort of strange sensations. You also lose your positional sense. Vitamin B12 is important for your proprioception, knowing where your body is in space, as well as fine touch, really trying to gently touch something and see what it feels like. All those things are going to be affected by your vitamin B12 deficiency. That's not going to be there in folate deficiency. So if you see anemia plus, your patient is reporting that they're falling down left and right, think about vitamin B12 deficiency. So that's your first big difference. Second big difference is in your labs. Okay, and this I'm going to put 2 stars by because, I mean, this is just, if they give this to you, they are handing you the question. This is like, if they give this to you, it's like, thank you, Jesus, for giving me this free question. I'm going to move on to my next question. In the labs, if you see elevated homocysteine, that can be B12 or folate. They both have elevated homocysteine. But if you have increased methylmalonic acid, that can only be B12 deficiency. If they tell you methylmalonic acid is increased, that's B12 all day, and all day today, all day tomorrow, all for next week, and all the time after that. Basically, consider it. Increased methylmalonic acid is always your B12 deficiency, okay? And so that is money. If they give you that, click your B12. Your patient must be some sort of vegan because B12 comes from meat. They may have some sort of lack of intrinsic factor. We talked about how intrinsic factor is necessary to absorb B12. If they lack intrinsic factor, maybe that's the reason, but it's something to do with B12. It's something in that B12 world. Pick that answer, keep it moving, okay? Great. So, what else can we say about this? Not much. Really, look for these hypersegmented neutrophils. This is a dead giveaway. Increased methylmalonic acid if it's B12, increased homocysteine if it's folate, or B12 as well as folate. You'll see that there, and that's about it. Questions on this one? I'm telling you, if you get a question on megaloblastic, I want this to be a slam dunk for you because it's very easy to tell the difference, and they love asking about this. They love seeing if you know that methylmalonic acid is only there for B12. They love checking if you know that. And if you know that, that's going to be another point towards you doing really well in your STEP exam. Okay. So last thing I'll say here, vitamin B12 has long-term storage. The storage for vitamin B12 is about 9 months. And so if you stop eating animal products, it's going to take about a year for you to start becoming B12 deficient. Other causes, say you have a patient that says that he eats plenty of steaks all the time, but you see a B12 deficiency. It could be pernicious anemia. We talked about this in our GI chapter. This is where you have an antibody that destroys parietal cells. Okay, and parietal cells are those cells that make intrinsic factor. Okay, so if you lose your parietal cells, you lose your intrinsic factor, you can't absorb B12. Crohn's disease is causing a inability to absorb intrinsic factor that's bound to B12, so those problems can be there. In terms of folate, this is short-term storage, and so if you have a deficiency of folate, this is a deficiency of green leafy vegetables. Think about your alcoholics. Alcoholics often drink alcohol instead of having a normal meal. And then there's also cases of increased need. So in pregnancy and infancy, you need a lot of folate. Okay? Great. So these are the labs that we talked about in the last slide. So here's a quick review of some of our different anemias and quickly how to identify them. When we meet again on Wednesday, we are going to talk about hemostasis, stopping the bleeding. What do platelets do? What is our coag pathway? Why do we care about it? Okay, and we're going to talk about all the problems there. All right. So fun lecture for